plenty of real literature. So epinephrine, moving down the line. We've got to throw in a little bit of radishes there in our salad. So we might want to choose epinephrine for our patient. You can see its mechanism up there, alpha-1, beta-1, beta-2 blockade. And so that means the alpha-1, it's going to vasoconstrict. Beta-1, it's going to increase the heart rate. Beta-2, it may vasodilate, so it may actually potentially make the patient hypotensive. So how can that be good? Obviously, alpha-1, beta-1 stimulation sounds good. Our hypotensive patient, beta-2 stimulation, not so good, right? Just to look at some studies, this first one was actually, Dr. Weinberg actually talked about this study, if anyone saw his lecture earlier during the conference. But rats poisoned with bupivacaine until asystole, given intralipid, the IFE, and then escalating doses of epinephrine. And so they actually found that higher doses of the epinephrine, less of the rats would actually come back and have return of spontaneous circulation. So if you're in that situation, a high-dose epi may be a bad choice, and maybe just the intralipids and a low amount of epinephrine. The next one, the quetiapine paradox, were a couple of cases where they actually gave epi and they became hypotensive. So we don't want that. Their discussion of this was that probably it was that beta-2 effect, and that it vasodilated and they actually became hypotensive. That third one there, the theophylline, is a case where, again, they became hypotensive with epinephrine. And we know theophylline is a peripheral vasodilator, and that certainly, with epinephrine, could have made that worse. All right, so in review, we see that the good things that epinephrine does is it will work on that alpha-1, right, beta-1. So it may cause, alpha-1 may cause some vasoconstriction, right, if this is a myocyte of your peripheral vascular system. And it may cause, through the beta-1 action, your heart to go faster, and you get better contractility. All right, on to glucagon. So we know that glucagon increases cyclic AMP, and that's important because if you have a beta blocker that's blocking that increase in cyclic AMP, you have a circuitous route around that, right? You can give them glucagon, it will increase cyclic AMP, increase intracellular calcium, and therefore increase contractility. The good things with that are that you may have an improvement in your heart rate, in your blood pressure. Some of the studies have even shown conduction improvement with glucagon. The bad things are, we know it increases your blood sugar. We know it can make you vomit, so that's not good, right? If you push that real fast, they'll just throw up all over, and that's just a big mess. And they may even have a vagal episode from that. So going on to the studies, this imipramine study, or actually this was a case report, imipramine, dithiapine, so 2 TCAs where they actually successfully used glucagon to reverse that toxicity, as well as in a calcium channel blocker. So it's not, some people consider glucagon only for beta blockers, right? You hear that as the only choice for a beta blocker. Well, I think those 3 cases right there show you could maybe expand that. The study number 7 here, and you will see in the handout, these are all referenced in there if you want to look at them or read them too. So in this one, they poisoned dogs with verapamil. They gave them glucagon, and they found benefit in that. And these are other case reports of success. So calcium channel blockers, 2 different ones here. And then this one was interesting about hyperglycemia, right? So if you give someone overdoses on a calcium channel blocker, right, we get hyperglycemia, right? So if you give them glucagon, does that get worse? And so that's what this study looked at. The same group that poisoned these dogs poisoned some more dogs, and they poisoned them with verapamil, and then they checked their blood sugar. And initially at 10 minutes, the glucagon group had a much higher blood sugar. the saline group or control actually had a higher blood sugar at 60 minutes. So the glucagon group actually had a lower blood sugar in this animal model. And so they sort of hypothesized that maybe they secreted some insulin and then that actually lowered their blood sugar. So there's probably not a big concern with that either. This was a study in rats that you see high doses of glucagon, 2 milligrams per kilo. So you can imagine in a human that could be a lot, right? So successfully reversed amitriptyline toxicity. The second one there on the list, they found glucagon was better by itself than in combination with glucagon and phenylephrine. And then you see the 3 reviews kind of varied in their opinion on what was best here. So this one, no evidence, they felt, that this actually helped a TCA, a beta blocker. And then this one thought, well, only animal evidence. And then finally this review felt it might work for a beta blocker, for a calcium channel blocker, or imipramine. And so my take on all these reviews is that, we have this sick patient. It makes sense from a mechanism basis. And I think as long as there's not much of a downside in giving the glucagon, so I probably would give it in those situations of that last review. And then this last case is interesting. It's a clonidine, nifedipine case that responded to glucagon. All right, so just to reiterate here, we want to increase cyclic AMP, right? Because this opens calcium channels, and they'll come in and bind to troponin. That myocardium will contract, or in the vascular system, or I should say the myocardium will contract, and you'll increase contractility. So if you block this with a beta blocker, then you can give glucagon and go through the same pathway. So that's why it works. So if they give our glucagon, our heart's going to contract more. All right, on to calcium. So calcium, we know it's great at intracellularly. We've talked about that. Can increase contractility. The bad things is calcium toxic potentially? What do you think? Yeah, right. I mean, it's potentially a toxin if you give too much. If you use calcium chloride, it can cause sclerosing of the peripheral vasculature. So those are potential bad sides from that. And then going through these studies, this was interesting, used in rats. They poisoned them with dicipramine, and they challenged them with either calcium or sodium. The sodium was better at reversing that QRS prolongation, and that makes sense according to what Dr. Bryant showed, right? Its effect on the fast sodium channels. They tried this other drug, 4-aminopyridine. That didn't really work too well. The other issue with calcium is digoxin, right? So what's the issue with digoxin and calcium and hyperkalemia? Right? It's stone heart, right? Sudden death. And you probably have been told that or heard that, or maybe someone's even said that's not true, but it's often one of our tox urban legends, I think. But this case right here was a abstract here of a woman that was chronic dig poisoned, was hyperkalemic, received calcium, and had a cardiac arrest within 15 minutes. So, certainly a possibility. We know that digoxin is going to poison that sodium-potassium ATPase pump. You're going to increase the intracellular calcium. So it makes sense if you give them more calcium, they're going to have this just tetanus-like heart, right? It's just going to be a rock. So it's not going to be able to relax. It's not going to be able to increase this stroke volume because it'll just be tight. So these other studies are looking at just that issue. And so this one was trying to see if you gave dig therapeutically in a verapamil poisoned dog and you gave them calcium, would that actually help them? Because dig would may prevent some of that calcium that's in the cell. And it wasn't that great as a therapy, but I think what's interesting is that there wasn't anything bad that happened to the dogs when you gave them this digoxin and you gave them calcium. Right? You would think something, they would have had a dysrhythmia and died. This one right here, the swine poisoned with digoxin, they kept poisoning until they saw a big peak T wave, hyperkalemia on their EKG, and then they gave him calcium, and then they gave one group normal saline, and they wanted to see how long would it be till they died or had a dysrhythmia, and they really didn't find any difference. There are, of course, some cases from the 1920s, 1930s where people did give, or did die, I should say, from, well, we'll just say they died. They're given digoxin, they were hyperkalemic, and they were also given calcium. And so that's some of these cases here. There's some early animal studies that they show that that was actually true. But then in this final one here, they looked at patients that, retrospectively, that were DIG patients that were hyperkalemic and got calcium, and there were no more dysrhythmias than the ones that didn't. And like I said, these are from the early literature, some human deaths. And this one, they were these dogs poisoned with digoxin, given calcium, did not find a significant issue. This letter actually suggested treating with magnesium for hyperkalemia, so just to avoid the issue altogether. There's a really, really nice review here that talked about this very issue, the hyperkalemia and the digoxin poisoned patient and the calcium. And their sort of bottom line was that maybe you just don't push it so fast. And if you see clear hyperkalemia, you see peak T waves, you see the sine wave, you treat that, but you also would treat with dig-fab fragments if you saw clear dig toxicity, or you would treat with both in that situation. And finally, sort of going out of the dig and the calcium issue, there was this fatality. So I used to think, yeah, nothing's going to happen. You can give them plenty of calcium and nothing will happen. Well, this person got over, it was just over probably a 24-hour period, maybe 30 grams of calcium, had a level of 32, went into renal failure and eventual multi-organ failure and died. Not acutely, but did die from hypercalcemia. So I think that's always good to keep in mind when you're making this decision. This was another animal study where they found these isolated guinea pig hearts would get poisoned by digoxin, and then when they gave them calcium, they would have dysrhythmias. And then lastly, this was a case where cardiogenic shock occurred. They gave calcium and revived the patient. So I think in summary, when it comes to the dig poisoned patient, they're hyperkalemic, you're concerned about that, you know calcium is one of the antidotes. I think you certainly can choose other antidotes. There are other choices. I think you probably could give calcium if there was a concerning EKG or they were unstable. I certainly would give them dig-fab fragments as well. And I think the other take-home points are really, you can give too much calcium, as we know from this one case report. All right, so calcium, we're going to flood it in through the channels. We're going to increase calcium within that cardiac myocyte. We're going to get contraction.